Hello, everyone. I'm so excited to present on this topic today. I had been studying suicide and adolescent development all through graduate school, and this is actually my dissertation project. So I'm excited to share with everyone today some of the research and some different interventions that we can utilize within our own clinical practice. If we want to have questions, I'm open to asking them throughout, or if it's easier, we can ask them at the end. Whatever works best for people is totally fine with me. I'm going to get started. So my dissertation research was really focused on protective factors and intervention modalities that would reduce the risk of suicide in adolescents. So what's been interesting that I found off the bat was that regardless of interventions that are going on within our community and within different practices, suicide continues to increase. Suicide in various attempts have actually doubled in the last decade. So I found that was very interesting and kind of got me interested in this topic because of not only the growing issue of suicide, but then also the way that our modalities have actually not been as impactful as they could have been. And so I really targeted adolescent populations because this group specifically has been in a heightened risk. So the largest increases seen among adolescents between two age groups, 15 and 17 and 12 and 14. So those are the two groups that I mostly studied. Current research shows that suicide rates for 15 and 19-year-olds are actually at their highest level since year 2000. In addition to the COVID-19 pandemic, attempts have increased across different ages and especially within adolescents. In COVID-19 alone, girls aged 12 to 17 in the summer of 2020 continue to show elevated length of attempts as well as number of attempts of suicide as well as self-injury. So suicide continues to be a significant problem for people within the age group of 12 to 25, and especially since COVID, we have also seen in clinical practice a lot more suicidal ideation and challenges going on facing depression in the community. So my research questions that I focused on were, what interventions do therapeutic day school staff members use to support clients with suicidal ideation? So I had focused on a school population. How comfortable do staff members really feel working with this population in crisis? What interventions in therapeutic day schools are working well for adolescents at safety risk? What areas of additional training in suicide prevention could be helpful for the school community and clinical community? Are the interventions utilized with the staff to address the needs of students in crisis really consistent with current research on protective factors? And I'm going to talk a little bit about suicidal ideation so we can just get a foundation overall with what the main term is and what that means. So I talked a little bit about how suicide has been increasing, but suicidal ideation is actually the first step of having suicidal thoughts or behaviors. And so suicide has actually been the second leading cause of death for adolescents out of all health issues, including heart disease, diabetes, accidents. So there's been a lot of different challenges that adolescents face, and suicide is actually one of the biggest causes of their death, which is pretty sad for that population. Suicide also can be caused by self-directed injurious behavior with an intent to die. Each day in our nation, there are average of over 3,703 attempts by young people in grades 9 through 12, and these percentages were applied to 7th to 8th graders. And then since then, the numbers continue to increase. So that was from 2018, and they are continuously on the rise. Suicidal ideation is defined as thinking about, considering, or planning suicide. And 4 out of 5 teens who attempt suicide were actually giving themselves to the population clear warning signs. So there are a lot of warning signs that we can see within this population that can be helpful for us as professionals to understand the next steps and create safety planning and interventions to support them. Some warnings to go into detail are suicidal threats, depression, anger, increased irritability, lack of interest in activities, sudden increase or decrease in appetite, sudden changes in appearance, dwindling academic performance, preoccupation with death or suicide, and previous suicide, and making final arrangements. So that would be like writing letters or giving notes. Foundations in adolescent development. So when looking at this research, I found it interesting when looking at just developmental history of kids and kind of how they adapt and grow within their school system, family relationships, and in their communities. And it seems that they face an identity and role confusion that is linked to suicidal ideation and thoughts. Identity and role confusion is really takes place in adolescence between 12 and 19 years old and explores values, vocational goals to perform personal identity. So a negative outcome can take place when there's confusion about future roles and not knowing their place in society or where they want to go. They also may face an identity crisis, which Erickson really describes as an identity development and conflict and a generational issue as youth are aiming to find themselves in a world that is ever changing. So ever changing can encompass social media, differences in technology, ways that adolescents are adapting to their environment. They can go through different crisis moments and not knowing who they are as an individual and what their place is in society. Some cognitive factors that take place as well is when adolescents and children are able to take others' perspectives and reduce their emotional reactivity, they're better enabled to engage in pro-social behaviors. So I'm going to be talking a little bit more about pro-social behaviors when we get to protective factors. Friendship. So that also goes into either a supportive environment or a not so supportive environment for kids. We know that peer variables do predict loneliness across the transition through adolescence, as well as if you have engagement with peers, there's acceptance, a number of friends, friendship quality can all play roles in suicidal ideation and behaviors. And then risk factors. So I'm pretty sure that a lot of people are familiar with risk factors, so I'll just go over them briefly. But they're individual, relationship, community, societal factors that take place. I also researched the Adverse Childhood Experiences study, the ACEs study, and that's something that we actually use here in our practice, which I was so glad to see because it's really helpful to get a lot of different background information, especially for teens and children, because half of adolescents at least have had one adverse experience, and nearly 1 in 10 have experienced 4 and more. So if you experience 4 or more, you're actually more likely to lead to death in adulthood. And death means physical ailments such as diabetes, heart disease, hypertension. So experiencing significant trauma events can lead to physical health outcomes, which was researched through that study. And then also, like I said, in the COVID-19 pandemic, suicide has been a significant problem, and there has actually been an increase of emergency visits throughout the COVID-19 pandemic as adolescents had been taken away from their school environment, they've been remote, they've been online, they've been having a hard time regulating their feelings and connecting with others in their community, which has led to an increase in suicidal ideations and attempts across the society. So now we're going to dive in deeper to protective factors. So what are protective factors? These are factors that mitigate the risk of suicide and buffer individuals from suicidal thoughts and behaviors. So why is this important? So if we have so much research on risk factors and things that are like warning signs for teens, why don't we also have things that are supportive and things that we can influence their life and engage them within their own life so that way they feel more complete and whole? And so there's a variety of different aspects of protective factors, and they come from all different realms. There's cognitive factors, parenting styles, protective support factors, school guidance, as well as PACEs, which is an additional study to the ACEs study, which I'm going to talk about in a little bit. So overall, cognitive factors that have been really protective for teens have shown the ability to respond to negative affect with distraction and problem solving supported against the risk of having suicidal ideation. So that would link into those DBT skills of distress tolerance and feeling able to face a challenge and feel confident in coping through cognitive specific factors. Also, parenting styles in adolescents have shown as really supportive factors. There's been a lot of research on authoritative parenting styles within families that can contribute to quality of emotional bond in the mother-father-adolescent relationship. So fostering a more authoritative parenting style is really helpful within the family dynamic. Protective support factors, so like social support of family and peers. It's actually really important for teens to have one identified best friend. So having one friend and one peer that they can go to has been a really big implicator for not engaging in suicidal ideation or not having thoughts about it. Help-seeking behaviors, so not only helping others, but like allowing others to help you as well. The role of mattering. So mattering is a term or belief that one can make a difference in another's life. So as the self-concept is forming in adolescence, a failure to matter to others may create vulnerability in teens and lead to thoughts of harming oneself. So creating a foundation of mattering and place in society, place in the community, or in the school system can be really helpful for that age group. And then also attachment relationships, and that goes into parenting styles as well. We all know that attachment, if you have a secure attachment to a caregiver, you're more likely to engage in pro-social behaviors, engaging in safe behaviors, as well as creating attachment bonds with other peers, other adults, and other people in their own world. And then school guidance. So family connectedness and school guidance have actually shown protective factors for depression, anxiety, and stress. So school guidance can look like either not only just having a guidance counselor that someone would go to, but really just having one trusted adult that they can go to in times of need. And then the PACES study. So I'm going to talk a little bit about this and what this looks like. So it really studied relationship factors and protective resources. So PACES stands for protective and compensatory experiences that can counter ACEs, variables and stages of development, including individual, family, and community levels. So if we have all these ACEs experiences, what can we do with them? We can create PACEs, which are these protective experiences. So some examples of those are relationship factors. So creating unconditional positive regard, love, belonging, having a best friend, volunteering in the community, having a social group. So feeling like you're a part of something. And then protective resources, these are having like a clean and safe environment, feeling nourishment, opportunities to learn and grow, and just having those resources that they might not have had at a different age or a different stage in their life. So, like the ACEs study, there actually is a survey that people can take for PACEs. So it's actually kind of helpful if you're wondering with your population or with your teen that you're working with, what kind of protective factors do they have right now and what could they benefit from, then you can give them a survey similar to the ACEs. They're similar within like yes or no questions. They talk about when you're growing up prior to your 18th birthday. They explain like unconditional love. Did you learn to have a best friend? So it goes through all the different categories about like hobbies and trusted adults and all of those things. So that way you can understand how many protective factors kids have and which ones we can work to increase to mitigate the risk of having suicidal thoughts and behaviors. So crisis interventions. I know some people are familiar with the Suicide Prevention Lifeline. Another popular topic that's been trained within a variety of different systems is nonviolent crisis intervention. Not sure if many people are familiar with this, but it looks at not only like physical restraint for kids who are in danger of harming themselves, but it also looks at empathy, compassion, and respect for working with clients that are in crisis. So there's a lot of de-escalation techniques and different things that adults and professionals can use in order to de-escalate situations. They're also pretty trauma sensitive. Nowadays, they've adapted it throughout their training, as well as being more person-centered. So I really like this intervention because I found it's been helpful for teens specifically to look at all different guiding principles of care, welfare, safety, and security. And if anyone has any questions about this, I myself have been trained in this as well. If anyone wants to learn more about it or is looking for needs for like de-escalation strategies and things like that. And then the Suicide Prevention Lifeline. So this lifeline has reached 60,660, oh my goodness, visitors and now will expand from 12 to 24 hours a day. So what was interesting is that I was doing my research study when they were developing the 988 code in 2022. So it was like this really big thing in the suicide community that this was the next biggest thing on the market to kind of create support and transfer callers directly to the hotline. And so I found at our practice too that we really emphasize this with our clients and really let them know that they can have direct help outside of our own therapy services. And this has been really impactful since 2022. And then also just fostering resiliency and utilizing protective factors have shown to be really helpful in mitigating risk for crisis. So I know that's a lot of background information, and this is how my study design looks, but overall, it basically was a qualitative and quantitative study. So I collected archival data as well as interviewed staff members within a therapeutic day school setting. My participants included different documents or documentation from a variety of different adolescents within the school system. So archival as in going back in history and looking at future cases as well as current. In addition, I also interviewed different staff members. And so I did interview styles. They were via Zoom because it was in the pandemic. And there were teachers, therapists, supervisors, and different aides that I interviewed to see their experience working with crisis and gaps in training or ways that they can improve their intervention styles within the school system. So my archival data, so I looked at 18 occurrences of suicidal ideation in adolescents within the school system from August 2017 to July 2020. And half of the documented students had reoccurring instances of suicidal ideation, as the other half had one event documented. I found this was interesting that if it seemed like it was pretty common if you have a suicidal thought to have another one or to re-engage in suicidal behaviors after engaging in them initially. My data collection also found incomplete and insufficient data for the timeline. So based on the research that was noted, it was really noted that suicide is actually a lot more common in teens and is really a fostering issue within society that some professionals or some school systems might not be seeing on the exterior. And then results also showed a reduced documentation of suicidal ideation. So this kind of looked at how they were documenting safety measures and ways to improve upon documentation. And it really saw that we weren't documenting it at the best, most detailed way. Like they had it documented, but it wasn't as documented as it could be to inform like future interventions. So there was a greater need for data collection and data-driven actions in order to better understand prevalence of suicidal ideation, just specifically within that school system. And then staff interviews. So I interviewed a variety of different staff members based on their training levels. So their experiences with working with youth. It was a school that saw kids from, I think it was first grade all the way through age 22, because they had certain extended programs that kids could engage in for employment. And so depending on the years of the professional and the years that the client was in the school, they varied. So the therapists and supervisors have the most experience working with adolescent populations, which makes sense because they're the ones that are seeing the kids daily and the ones that they're doing therapy with them. It also showed that therapists and supervisors provide most interventions for suicidal ideation and behaviors by providing brief risk assessments. So those are the ones that are like on the fly, the ones you do a quick check-in, ensure safety, and then they get back to class. Therapists and supervisors also provide interventions that include therapeutic support, collaborative team approach, brief risk assessments, safety planning, and communication with caregivers. So the school system was really good at connecting with the community, not only with the kid, but with their family, with their community outreach or whatever program or system, extended system they were a part of outside of the school in order to gain resources. And then I reviewed different additional training needs. For example, teachers and therapists shared they would benefit from learning more about risk and protective factors for SI and adolescent behaviors, risk assessment questions, and different tools for them to use within the classroom or within the clinical experience in therapy. So staff comfort levels. So I also not only looked at people's experience, but I was interested in the comfort levels of different staff members because suicide in general, I know can be a very difficult topic for people to talk about or even experience in their own clinical practice. And it kind of varies within the population based on experience as well as comfort level. And so therapists are the blue line. So they clearly are the most comfortable because they probably have the most training, they experience it the most. So some therapists had somewhat comfortable, Majority felt comfortable or like adequately comfortable working with students at risk or adolescents at risk. Teachers were a little bit lower on the comfort level, and they seemed to reach out to therapists to not only gain next steps for risk assessment, but to better understand their own comfort level if they were overwhelmed with other kids in the classroom or they were feeling uncomfortable overall. If something was happening that felt unsafe, they would just tap in the therapist. So they didn't have that direct one-on-one experience working with the kid. And then supervisors were also extremely comfortable. So those were the ones that in the like supervisors such as like clinical directors, supervisors that were supervising other therapists found that they were most confident in themselves and felt that they were able to handle different situations. And then discussion. So based on my research questions, I had found different results. And results kind of focused on, like I said, my specific questions, but we can talk more about discussion, and I have resources and different things that we can talk further about as well. So my first question was, what interventions do therapeutic day school members use to support clients with suicidal ideation and behaviors? So we found that the interventions that are widely used within that school system was creating a safety plan, enhancing communication, building rapport, identifying support, managing stress, and communicating with caregivers. How comfortable do staff members feel working with this population in crisis? So supervisors felt the most comfortable working with this population. Teachers who felt very comfortable also had more years of experience working with adolescents in crisis, which makes sense. And teachers also tend to reach out for therapeutic support from therapists and supervisors for risk behaviors. And then what interventions in therapeutic day schools are working well for adolescents at safety risk? Staff interviews shared therapeutic rapport, validation of feelings, collaborative team approach, brief risk assessments, safety planning, communication with caregivers are working well for adolescents at risk. What areas of additional training in suicide prevention would be helpful for a school setting or clinical population? So psychoeducation on current risk factors and protective factors, operational definitions of suicide, creating a safe space, understanding the differences between suicidal behaviors and non-suicidal self-injury, brief and consistent risk assessments, hospitalization steps, and documentation and follow-up. So it sounds like they really could benefit from a lot of different resources and a lot of different updated research that has been currently collected like by the CDC or by different professionals. And then are the interventions utilized by staff to address the needs of student in crisis consistent with protective factors supported in research? So protective factors include the safe space, the social support, having a trusted adult, and a relationship outside of home, and then a school connectedness. So some of the resources that they were using did incorporate like the school support as well as a trusted adult. However, a lot of different resources for suicide actually don't really incorporate too many protective factors. They look more at risk factors. So this would be something to emphasize within the school system or within clinical populations as well. So further recommendations and future implications. So these are different resources and things that we can use within different systems to make sure that suicide is a taught topic and is talked about, as well as taught to clinicians on how to understand and treat adolescents with suicidal ideation. So some recommendations would be a uniform approach to training. So all staff members, due to varying experience working with the adolescent population, they were working in classrooms, therapy settings, as well as school activities. So not only having a uniform training approach to like just supervisors or just therapists, but everybody involved. So within the clinical practice, this could be really helpful to have like a specific training on suicide where there would be like upon entry, understanding what risks are, what suicidal ideation looks like, risk factors, protective factors, and ways that we can really create a uniform approach. So that way there's consistency in documentation and interventions utilized, which then the next recommendation is improving documentation of interventions. So having a standardized approach to documenting suicidal behaviors and thoughts is really helpful, not only for like the client themselves, but also for ongoing research as well as systemic challenges, whether there could be like a legal issue down the road, insurance issue, and so on. The more documentation, the better, is definitely a lot more important than like just kind of checking boxes or not feeling like you're expanding upon the information given at that time. And then adolescents, ACEs and PACEs scores. So not only using the ACEs study, but using a PACEs study. So looking at those protective factors that we talked about. And research has shown that, of course, adverse childhood experiences are very common within this population, as well as protective factors. And I think it's important to look into different things that teens are experiencing that are positive, which they can engage in and emphasize within their life. So that way they feel more fulfilled and less likely to have thoughts or engaging in suicidal ideation or behaviors. And then future implications. So this data set that I have studied is really just a starting point to better understand how protective factors and interventions are useful for teens with safety risk. And clinicians can better learn and utilize clearly measured effects of interventions to inform evidence-based practices. In order to reduce the risk of suicide in adolescents, school clinicians need to be well informed on risk and protective factors, as well as the clinical population, in order to not only work with adolescents that are currently at risk, but prevent adolescents from being at risk. So looking at the root cause and creating an early intervention modality or strategy. And then collecting information from other populations can be helpful as well. So collecting documentation from clinical populations or other schools to understand, is this a single school issue with documentation and so on, or is this more a widespread issue within different systems and larger systems such as hospital settings or intensive care units? It also may be possible that public schools could be documenting these cases even less than a therapeutic day school. So understanding the barriers, whether that's resources or professionals or different areas within this society in the United States, as suicidal ideation continues to be increasing. We want to make sure that we can try to create a lot of different supportive environments in a variety of different systems as well. And then I think I listed some resources. So I have a variety of different resources that I can go over as well. I'm not sure if we want to like pause our discussion and I can answer any questions before I go into resources. Otherwise, I can just jump in to suicide resources as we're near the end. Resources would be helpful. Awesome. Okay. So I'm going to go over the resources and then feel free to ask questions about the resources and different links and stuff. I can always send them directly to you, or I can show you how to access them. Okay. So specific resources. So You Matter. So You Matter is a safe space for youth to discuss and share stories about mental health and wellness. So it's created and administered by the National Suicide Prevention Lifeline. So You Matter, if you look it up, it's basically kind of not really like a chat room, but kind of a way that people can share their stories and feel connected to foster resiliency within the teen population. The Trevor Project. I'm not sure if many people are familiar with this one, but it's been a really great non-for-profit organization that was founded in 1998, and it focused on suicide prevention efforts among lesbian, gay, bisexual, transgender, queer, questioning youth. So it's kind of like a toll-free telephone number and operates the Trevor Lifeline. And it's also a confidential service that offers trained counselors to specific individuals. And then the Not Okay app. So this is actually one of my personal favorite tools that I've been using with teens before. So it's a pre-crisis tool, which is kind of cool. It's like an early intervention tactic. So what it is, it's like an app just on your phone, and it's used for youth to access their support system quickly. So they're accessing their own internal supports without having to ask a counselor or additional services in an emergency. So what it'll do is it will notify your trusted contacts that you've been selected as your support group. So when the time comes and you need to reach out, you'll just have to open the app and press a large red button. And pressing the button alerts your support system. So your best friend, your trusted adult, maybe a parent. So anyone that you feel like you need to contact for support, it links you right to them. It also links your location. so like where you are. It also links crisis lines. It gives like coping skills and additional resources on the app as well. So this one I feel like is pretty easy to use for most teens, and they kind of are more willing to use this one because they know it's like just their own contacts. So that's not like they're talking to a stranger. So this one has been really helpful. And then another one I want to talk about, Active Minds. So Active Minds is actually a growing movement to reduce stigma in youth regarding mental health overall. So Active Minds was founded by Allison Melman when she was a junior at University of Pennsylvania, following the suicide of her older brother and only sibling. So 1 of every 5 students lives with a mental health condition, as we know, but the stigma and shame were preventing students from reaching out. So the only way things could get better, she knew, is if she could get people to talk about it. So what's really interesting is that this website gives openness as well as creativity and feeling like you can belong somewhere if you're feeling alone. So it provides different stories, resiliency stories, as well as can give like a space for reflection and a supportive environment to reduce stigma on mental health because it is so prevalent. And then there was one other, Ditch the Label. So this is a global youth charity. So this is where ages 12 to 25 navigate issues affecting them the most, from mental health to bullying to identity and relationships. So Ditch the Label is like another way to ditch the label of like, oh, I have bipolar disorder. Oh, I have suicidal behaviors. So ditching a label from a diagnosis and looking at the person. So it's really person-centered and can be helpful for youth looking to kind of feel like they belong in a community and not feel they have to label themselves just to fit in somewhere. And then I also, the National Suicide Prevention Lifeline. I know everyone's familiar with that one. There's a Veterans Crisis Line. I don't know if many people are familiar with this one. But this one can be helpful not only for veterans, but their families. So a lot of different teens and children that are working on their own mental health, this can be a helpful crisis line as well. And then the crisis text line, I'm not sure if people are familiar with this, but you can text hello to a certain number. It's free, it's 24/7, it's confidential, kind of similar to the 988. Let's see, did I go over all of them? And then I just listed like 5 action steps. So just really, really basic action steps to do, which are ask, keep the client safe. You want to be there for them, stay connected, right? Help them connect to someone if it's not a professional, and then stay connected with them. So the follow-up, which I think sometimes clinicians or like different people kind of forget about the last part about like following up with them. Like, so if we give them the resource, we want to make sure they access the resource and are benefiting from the resource, because some kids, if you give them a resource, they're like, I'm not doing that. Like, I don't care to talk to them. And so it's important to follow up with them and make sure that they are staying connected with someone that can help them in the time of need. And then the last part is talking about language about suicide. So this is really important, I think, to reduce stigma overall about mental health, but then have a better understanding and awareness as a professional, like how we are talking about suicide, how other people talk about suicide. It's kind of just giving an informed perspective about ways to talk about it. So I just created this chart. It just says like, instead of saying this, you can say this and like why. So for example, a lot of research has shown that it's not helpful to say commit or committed suicide in the dialogue. It's actually a lot better to say died by suicide, death by suicide, or lost their life to suicide, because saying commit implies that suicide is a sin or a crime, or that it's something that can be accomplished. And then instead of saying it was successful or unsuccessful suicide attempt, or completed or failed, we want to continue to use language such as a fatal suicidal behavior, non-fatal behavior, died by suicide, lived through a suicidal attempt. So you're basically making sure that we're doing the person first instead of labeling the attempt first. And this is because the notion of successful suicide is inappropriate, because it frames a really tragic outcome to an achievement or something positive. And then saying that suicide is like an epidemic or that it's skyrocketing is also not very helpful because it can create fear and then also stigma on the topic. So we want to use words such as increasing or rising issue within the population. So by using purely quantitative, less emotionally charged words can be helpful to create discussion and less feelings of, oh, this is like a doom and gloom experience. And then, like I said, we want to use person first. So instead of saying person is suicidal, we want to say person is facing suicide, has suicidal thoughts, has suffered through suicidal thoughts, and so on. We don't want to define someone by their experience with suicide. They're more than just their thoughts. And then the last one talks about stigma related to mental health overall too. So we don't want to use words such as like the mentally ill or she's bipolar or she's suicidal, he or she. We want to say that they're facing something, they're facing a challenge, they're facing a diagnosis, person with mental illness. And this is just putting the condition before the person reduces someone's identity to their diagnosis. So people aren't their illness. We want to say that people have an illness, not that they're labeled by that. So using the person first language can be really helpful as well. And then I think I just have resources and different books and things. So if anyone needs any other resources, I've way more than this. I just tried to put on like the main ones so people can look into them or ask any other questions as well. Okay, so I am done. Should I stop sharing my screen for questions?
Sure. Yeah,
Okay.
if anybody wants to share questions or thoughts, I would say feel free to can put them in the chat or just go for it. Thank you so much, Dr. D.
Yeah, no problem. How can we access PACES? Okay, so there's a PACES website. Great question, Lauren. So I have like copies of the survey, which I don't know if I could just maybe send to everybody. Otherwise, we can probably access them on the website because I think it's really helpful. Lauren, were you thinking like you could use them with a client?
Yeah, I feel like that'd be really helpful, especially with like the teens that I'm working with right now. A few come to mind. So,
Oh,
yeah.
good. Yeah, I'm glad to hear that. Yeah, I found it's really helpful. Sometimes teens like doing them like by themselves, or sometimes they like having you read them or discuss it with them. Because sometimes teens also have difficulty saying they have the resource. So like we can name 5 friends they have, and they can say, I don't have any friends. And I'm like, well, you have this person, this person, this person, and so on. So sometimes it's helpful to like coach them through it also. So you can just ask their preference when you give it to them. Great question.
Other questions or resource help? Maybe they'll come up after.
Yeah, I know it's also like an emotionally charged topic, so I do understand that. And if people don't have questions now, that's totally fine. You can also meet with me individually. I'm very open to that. If you want to talk about like certain cases or certain issues that you might have on a one-on-one basis, we can do that as well.
That's very generous of you. Thank you for that. Okay, well, yeah, feel free to take Dr. D up on that. But this was so wonderful. It was great to, yeah, just learn from you. And thanks for such a great presentation as well. I'll go ahead and stop here.